Hello and welcome to Bottom Line. I'm Cindy Kainz. We have a very important and informative show for you today. We're going to be talking about Parkinson's disease and some research that's happening. What I'd like to do is welcome my guests for today's show. We have Dr. Ellenbogen. He is a neurologist and also the medical director at MIND, which is the Michigan Institute for Neurological Disorders. And also with us, Stephen Park. He's a Bloomfield Township resident who has experience and has Parkinson and been dealing with it for the last 20 years and provide us some personal experience. So welcome, gentlemen, to the show.
Thank you.
Thank you.
Dr. Ellenbogen, we'll start with you to maybe for the audience who's watching, who may or may not be familiar, what would be considered Parkinson's disease and maybe the history behind it?
So Parkinson's disease actually has a history where it was initially described by a man by the name of James Parkinson in 1817. And he wrote a paper describing people that he saw in everyday life. And he described a condition that involved tremor and slowness of movement and a variety of other conditions. And certainly that is the historical underpinning. One of the really main issues that we're seeing today is that there is an increasing number of people who have Parkinson's, and that number continues to grow. And so that obviously is a significant concern for us in the medical field and society in general.
Do you see more men or women having Parkinson's disease?
Parkinson's does have a male predominance. It's about 3 men for every 2 women who have the disease.
Okay. And when you, what would be some maybe signs and symptoms that you as a doctor, if patients come to you might have, or for people who are watching the show might look out for in a loved one themselves or friends?
That's a really interesting question because it is something that is very insidious in onset. And so there are symptoms that can emerge over years before people ever recognize that they have Parkinson's, because many of the early symptoms are not actually the ones that we recognize as being classic for Parkinson's. What I mean by that is there are people that will have changes in sleep habits, including something called REM sleep behavior disorder, where they're acting out dreams when they're asleep. And that can exist a decade or more before they actually develop the motor symptoms of Parkinson's. There can be changes in mood, depression, anxiety. There can be constipation, which is often an early symptom, loss of sense of smell. And while none of these are specific to Parkinson's, they certainly are something that can indicate that there's a coming problem. The first motor symptom, and really the most obvious motor symptom, is slowness of movement. In many people, there's a particular type of tremor called a tremor at rest or resting tremor. And as opposed to when people are holding their hands out or notice tremor when they're using their hands, the classic tremor of Parkinson's actually occurs when their hands are totally relaxed and at rest. We may see changes in walking. We can see changes in the ability to get out of a chair. And the slowness often manifests in just everyday activities. People find that they're slower when walking a distance. They may be slower with dressing or eating or activities of daily living like shaving or brushing their teeth.
That's a lot of, like you said, so many different signs or symptoms that could be a lot of different things that are going on besides just maybe Parkinson's. Stephen, would like to maybe just ask you, appreciate you wanting to share, some of your personal experience, and you've been dealing with this now for over 20 years. Could you speak to a little bit of maybe how it started for you or what it was like when you were first diagnosed?
Sure. Well, when it started with me, I was one of the patients Dr. Ellenbogen mentioned, which is I didn't have any idea that there was anything neurological going on. I thought I hurt my shoulder when I fell skiing, which I did, but my arm didn't swing anymore, and the physiatrist went to see the work on my arm, said, "Nah, I don't think you got an arm problem. I think maybe you need to go see the neurologist." I'm grateful way back then he recommended Dr. Ellenbogen. He looked, and I had a number of those symptoms. So that was 18 years ago when that happened. Prior to that, I had some of these other things that I didn't know what the connection was. Sleep. I thought sleep apnea was because I was anxious, but at any rate, I've been dealing with it since. I was also familiar with it because my dad had Parkinson's and passed away from complications related to it. And my grandfather had it as well. And he was in the early days when they had basically one treatment, and treatment was almost as bad as the disease. So I've been around it for a long time.
And Stephen, I think you bring up a really good point that I'd like to ask Dr. Ellenbogen. Is the hereditary or genetics, or can it be environmental that someone has, becomes someone with Parkinson?
That's a great question, because there's still so much that we don't understand in terms of what provokes people to have Parkinson's. The general thinking at this time is that for most people, there's a combination of a genetic susceptibility and some sort of environmental exposure that may then trigger development of the disease. To just provide a little more color in terms of that, for example, as Steve points out, he has a very clear family history and affecting multiple generations. And in a situation like that, we often suspect that there is a genetic predisposition. However, many people who have this genetic predisposition, even if we can't identify it, it doesn't mean that everyone who has the predisposition gets the disease. And there can be a variety of reasons why that is. There is some work from a colleague at the University of Rochester, and he's actually published a book on the idea of environmental exposures. And it's not clear what those environmental exposures may be. However, there's more and more evidence suggesting that there are things in the environment, including chemicals and potentially viral infection and so on, none of which have been identified as the smoking gun, so to speak.
It seems so variable, like you said, you could be a little hereditary genetic, it could be environmental, or, depending on what people get exposed throughout their life and so forth. Are there any kind of risk factors that we could consider? I mean, one is, of course, if you know your genetics, and in Stephen's case, his father and grandfather, but is there other risk factors out there that people should think about as well that could increase the likelihood of getting Parkinson's?
There really aren't any things that we can tell people to avoid in terms of identifiable risk factors. Certainly, one can't control their genetics. And at this point, even if we knew that someone was going to develop Parkinson's, we don't have a treatment that actually can slow down the progression. And that's one of the things that we're working on in our research at Quest, is trying to find things that may help slow down the progression of Parkinson's.
And Stephen, in your case, many years ago, since, 16, 18, 20 years have gone by, how did you see from when you first were diagnosed? What kind of things were you doing back then, or some changes you've made now in your lifestyle between then and now?
Well, there's almost everything. Everything I do has changed, at least slightly, some dramatically, but most of them haven't stopped me from necessarily doing what I was doing before. I just would do it slower, less well. I'm tackling new stuff like computer software and hardware things, which, I'm an engineer. I should be able to figure this stuff out, but it takes me longer. So you put the screws to your stress wise, let's say, and to get the sound fixed right now, all of a sudden I can't make my hands do what I'm trying to do, and it just makes it harder to talk. Everything sort of snowballs. So I think what it boils down to is you have less bandwidth. At least I have less bandwidth to deal with the thing multitasking like everybody is fond of saying they're good at, which in fact means they can just do stuff quickly. And because you could explain that better than I can, but I can't, tackle 3 jobs at once like I thought I used to be able to do. So I could still drive, but I don't talk on the phone. I'm trying not to eat. No, it's not a problem, but less multitasking right off the bat. I still drive my boat, but I'm not rescuing stray logs floating around in the lake, because it's too many things to focus on once, at the same time. So I think overall, it hasn't made me quit much of anything I can think of right now.
Right. And that's amazing. Thank you for sharing that, because I think that's so encouraging for people who are watching to say, okay, maybe I can't do three things at once. Maybe I can only do one, and I can focus on that, but I can still do that one or two, or, still you can do your boating, you can still drive, you can still do all those things. And do you, I have to ask if this is okay. Do you, when you're out and you're going out in public and that, do you be bothered by that? Or if you want to go out to a restaurant and have dinner and so forth? And
dinner is fine, just takes me longer. So
yeah.
Automatically have a 2-hour dinner if I'm going to eat everything, unless I'm in a hurry. And people's reaction is, for the most part, nobody says anything. But if I feel like they are noticing, 10 years ago, I just let it go because it wasn't particularly noticeable, I didn't think, and I decided, just don't bring it up. Now I tend to say something maybe earlier in a conversation with somebody just because they may be looking at me like, why are you tremoring, or something they can see. They can't see a lot of the other stuff. But if it's, what I think is obvious, I might bring it up. Oh, I have Parkinson's. And the good news is the more people know what that is, so they're less concerned about it. Oh, that's nice. And they got their own worries. Or you get a chance to explain it if they never heard of it. But I've been, I think, pretty lucky so far. I don't know about when we travel overseas, which we haven't much since I was getting diagnosed. I think it's less common that people know what it is, so it may be more of an issue than I'm not speaking full sentences and I'm having movement issues. So I think it's more likely somebody would look and wonder without getting clarification because we can't communicate as well.
Yeah, well, thank you so much for sharing that, and appreciate that. And I appreciate, you even sharing, like your personal experience, because like you said, if you feel that someone's kind of maybe uncomfortable, they're not sure what's happening with you, and you're just saying, you have Parkinson's and there's nothing wrong with that, versus anyone else, whatever has cancer or whatever the case may be when people have, different things that happen in their life. So, and I would hope that everybody be very understandable about that. So. And Dr. Ellenbogen, when we're talking about, and Steve is talking about how things, transition from, early onset to later, and that, what are you looking at? We're going to be talking about research that I know that you're doing. And before we go to that, is even though there's no cure, what are the common treatments right now before we head into then the research piece of it, if we could?
So the treatments that are really specific for Parkinson's are targeting largely motor symptoms. So the foundational therapy, and the one that's really been around nearly the longest, going back to the late 60s, is a medication called levodopa. And it's given with another medication that just helps it work a little bit more efficiently. And all that levodopa does is it gets turned into dopamine in the brain, which is the principal neurotransmitter that is missing in Parkinson's. So it's certainly far more complicated than that, but most of the treatments that we have are targeting that lack of dopamine. There are some other treatments to address some of the non-motor symptoms. There's a medication, for example, that's intended to address hallucinations for people who experience that. There's another medication that targets a different motor complication of Parkinson's called dyskinesia. But as you can imagine, and just in talking about what we do have available and talking about the broader context of symptoms that people with Parkinson's have, there's still a lot that remains out there that needs to be addressed, and having better strategies to manage those issues.
And one of the things that, a lot of people think with Parkinson's is the tremors. But I know we were talking a little bit before the show started, but maybe you can share what you were saying prior to the show of the percentage of people that have Parkinson's that may not have the tremors.
So although tremor is one of the most obvious signs of Parkinson's, it is not even the most common cause of tremor. And about 30% of people with Parkinson's don't have any tremor. And those who do, in most cases, it's not debilitating because it's a tremor that occurs at rest and often will dissipate or at least diminish when people go to use their hands. And so therefore the tremor is a little bit less of a problem than it might be in other conditions such as essential tremor, which classically the tremor comes out when people go to use their hands and do things with their hands.
And Stephen, I'm not sure, did you mention, do you have the tremors?
I was one of the no tremor people for a long time. And I don't know the exact date, but 8 or 10 years went by without any tremor, and I was able to keep the whole shebang under wraps. My dad was coming to end term there during that time. I didn't want to tell him about it, so he would go worrying about me, and also didn't have anything that anybody could see. So as for my wife and I and Dr. Ellenbogen, nobody, my regular physician, nobody knew about it. And then gradually I developed off and on, or still going on, a whole raft of the other symptoms, which each require their own little set of treatment. And some of them are sort of embarrassing, but not terribly so. I mean, you drool in public, people look at you and they can't help it. And it's okay, well, I don't do it very often, but it happens. And and everything moves slower through your GI, so for me, it's a lot harder time dealing with internal stuff. And I started listing symptoms. I got some of them could be something else altogether, but there's like 15 of the things. Wow.
Yeah.
Well, I think.
Yeah. Go ahead.
Oh, sorry. I think that Stephen points something important out there, which is there's this tendency when people have Parkinson's to blame everything on Parkinson's. And sometimes it can be very difficult to differentiate what's Parkinson's and what are maybe other issues. And especially because this occurs in an aging population as well. And sometimes one needs to remember that they're actually going through the aging process while having this condition. And so that's often one of the challenges that we deal with.
Yeah, exactly. Dr. Ellenbogen, let's talk a little bit. You are working on some research. Can you speak to that and what's happening maybe in the world out there, just for what maybe you're looking at, but maybe what else is going on to try to see how to help people who have Parkinson's?
Absolutely. So, there's a number of different avenues of research that we're involved with here at Quest Research. One of them, as I had mentioned before, is really trying to find things that may slow down the progression of Parkinson's. And that's for a very unique set of people. Oftentimes it's people who are in the either newly diagnosed and then not on any treatment, or people who are early in their course of Parkinson's, meaning they've been diagnosed within the last 2 or 3 years, and there may be some opportunities to participate in those kinds of studies. We are also doing studies looking at developing new treatments to help manage some of the symptoms of Parkinson's. And so one of the exciting ones that we're working on is CVN-424. And that investigational medication actually takes a novel approach in terms of how we are dealing with Parkinson's symptoms. So as I had mentioned before, much of the current treatment surrounds this idea of using dopamine, which is essentially, if you think of a gas pedal and a brake in Parkinson's, it's essentially as if someone's foot has been taken off the gas and simultaneously pushing on the brake. And dopamine is really just trying to step on the gas. What we're doing with some of the studies is actually working on treatments that may help release the brake a little bit and allow movement to happen more readily by reducing that pressure on the brake as well. And so trying to restore a more normal balance between those systems.
It's amazing that, to understand how to jumpstart the dopamine and kind of get that back in to help the brain and the stimulation and so forth. And for this kind of research, is there a tipping point for someone to say, yes, they could benefit or be part of these research efforts and clinical trials versus others?
So each study has its own particular set of criteria. And so that's something that, it's prescribed, where we have to go through each of what are called inclusion and exclusion criteria to make sure that people are the right fit. You never want to try to fit a square peg into a round hole. And a lot of that is really to protect safety of individuals who are considering enrolling in a clinical trial. And so, as a principal investigator in those studies and the medical director here at Quest, one of my main responsibilities and foremost of my consideration is ensuring the safety of those people who participate. The second responsibility then, of course, is to make sure that we adhere to a protocol so that we can provide the best data possible. One of the really exciting things, and it's been fortunate that I've been able to participate in a number of studies over the last 20 plus years, is that through the work that we've done, we've helped to bring a number of new treatments to market. And as a result, people who participate in a clinical trial, not only do they potentially benefit from participating in a study and having access to something earlier than others might, but they also can have a real meaningful impact on all those other people with Parkinson's who didn't ever get to participate. And so they're able to really pay it forward. And one of the things that I've found is that in general, people with Parkinson's, it's a very altruistic community. That I have so many people who have participated over the years and I've met that have said, even if I don't benefit, I hope that others will benefit from my participation. And it's really remarkable to see that and hear that from people who are going through something as difficult as Parkinson's can be.
And I think that's what's so important, like you said, just paying it forward. Maybe it doesn't help them, but by them participating, they could be helping the future. And, and then eventually maybe someday there could be a cure or something to at least help individuals. And Stephen, in your case, have there been any trials that you could be fitted for, or I should be, a candidate for? I know Dr. Ellenbogen is your neurologist.
Yeah, I've participated in a couple ways. Because I'm down the pipe quite a ways, I don't qualify for a lot of the drug trials, but I was an early tester for a smartwatch that wasn't called smartwatch. I forget who actually built the electronics, but the idea of it was to gather data on my patients' daily movements and stuff and be able to upload it, right to the office at Quest, and they could sort of look at real time, like instead of seeing me once a quarter, you're seeing what it looks like every day. The only problem I had with that is I kept losing my watch because I knocked on the side of the boat or tore off skiing or something. So I probably cost them a lot of money on lost watches. But the other one, that a very large study, the PPMI study, my daughter was a facilitator for one of the sites for that, and that was a peer research project, which I didn't do, but she knew about through my trials, I guess. And then 23andMe, I think, is a genetic. Dr. Ellenbogen could explain this better, but I've participated in a genetic study that's or anybody can do. It gives them a healthy baseline. So I haven't done as much as I would like to have, frankly, but I'm trying to do it in another way of helping them improve visibility and working with Michael J. Fox, with Michigan Parkinson's Association and stuff to sort of help improve visibility. This kind of meeting.
And Stephen, thank you so much for all that. We were just saying about paying it forward, all those things that you're doing and helping and participating and providing your own data on that is just amazing, because it just helps the future of this disease and that. And Dr. Ellenbogen, the patients that you see, and what do you think, with being the medical director there at Quest, that, how do you see the future of other research going on? I know there's a lot of emphasis that has been placed on this, and I know many years ago, of course, as Dr. Stephen just said, Michael J. Fox, brought attention to it, and it's anyone who's helpful to help other people understand, like people who might be watching the show. And that is there. Do you feel good and positive that this research is moving forward that can really help people as they age, and as the young generation becomes the older generation.
So I do feel optimistic, to be quite frank, to the point that Steve made about some of the things that he's participated in. We are seeing that research translate into clinical action. So the watch study, for example, we're seeing software that's being developed, whether it's using a smartphone or a smartwatch, that can help monitor people's symptoms of Parkinson's. And while sometimes it's easy to get in the weeds a little bit too much and try to tease out something that's going on day to day, when you take a step back and look at those in much larger pictures, those kinds of tools help us to optimize treatments that we have currently available for someone who is experiencing Parkinson's. The genetic study that he mentioned, in the end, there were 20,000 people who participated in it, and we just published the data within the last few weeks in the journal Brain. It was called the ROPAD trial. And so, again, that helps to foster additional research and really can make a difference in terms of our understanding of Parkinson's, and furthermore, develop specific treatments for genetic conditions that have been identified with Parkinson's. And there are studies that are actually now targeting specific gene mutations in Parkinson's, and in some cases, gene products. So people may not have a specific mutation, but they may have a similar underlying problem without the mutation. And so there are trials that are starting to work on that. So I think there are two things that are happening that really make me optimistic. Number one, we are going to have really much more individualized treatments down the road, because we can use that based on people's genetics or some of the biomarkers that are in development that we can measure. And number two, I do think that we are going to get to a point where we are able to really slow down progression of this. And that is the stepping stone to actually finding a cure for this disease.
And like you were saying, I think just that last bit so important, just slowing it down, so that, like individuals like Stephen, who's been dealing with that, maybe it would have slowed the progression half the time versus how it's progressed up to now. In Stephen's case, his grandfather, his father, if someone says, okay, I have it in my family, when do you try to address it? What might be an age, or do you have to wait till their symptoms? Is there kind of blood test or a genetic testing that could help someone know if they might, have this in the future?
So the answer is there are a number of tests which can help us identify if someone has potentially the early stages. There is a certain type of brain scan that can be done called the DAT scan that looks at dopamine in the brain. And these are sometimes being used as part of clinical research for really just trying to identify people in what is a pre-symptomatic phase of Parkinson's. So if someone has a strong family history, or if they have the right constellation of symptoms like constipation, loss of sense of smell, the dream enactment behavior that I'd mentioned earlier, then those may be people who are able to be identified early. There's also a skin biopsy that can be done, because for most people with Parkinson's, you can actually see changes in neurons in the skin as well. And so there's a test that's now available commercially that can be done by any neurologist. And although there are not many that are actually doing it at this point, but can be ordered and can give information about whether someone has those markers. And there's also a spinal tap procedure that can be done to look for those same sorts of markers in spinal fluid. And I think what we're going to see down the road is that there are going to be additional tests, including certain types of blood tests and so on, that will help us to screen for Parkinson's. But this becomes very important if we actually have a treatment that is approved to slow down the progression, because then we want to identify people as early as possible, because something even that has a small effect can cast a very long shadow. And so the earlier in the course of the disease that you can make even a modest impact can really have a large impact in that progression down the road.
Well, Dr. Ellenbogen, thank you so much for your expertise. Quest is very lucky with you for the medical director there to be able to, and I know Stephen has a great neurologist there with it. So thank you, Dr. Ellenbogen, for being on the show. And Stephen, thank you so much for sharing your personal experiences with us. I think, I know for me, it helps me understand more the things that, you're dealing with. And I think it's amazing because you look like you have such a great positive attitude to be helping others and still going through and boating and doing all those fun things. And you can see the sailboat in the back of your picture there.
A little small, but
yeah. So again, thank you both for being on Bottom Line. I thank our audience for watching, and I wish that hopefully this information can be helpful for you, a family member, or just so that you're knowledgeable. Thanks for joining us. I'm Cindy Kainz.
Thank you for having me.
Thank you.